everyone. I'm Michelle Laws, the Chief Experience Officer for the North Carolina Medical Society. And thank you. Thank you for joining us again for another segment of Public Rounds, the North Carolina Medical Society's podcast. As I have said before, our goal really here is to have really thoughtful conversations about topics that are of interest to the public. And this is May, and it is Mental Health Awareness Month. And that we could not let the month end without having a conversation about mental health. And particularly for this conversation, we're going to be talking about the connection between brain health and mental health. So sit back, take some notes, and hopefully you will find this informative and inspiring in a lot of ways. Our guest today is Dr. Trey Bateman, and we are honored to have you, Dr. Bateman, here. Why don't you tell our listeners a little bit about who you are and your background?
Sure. Thank you very much, Michelle. I appreciate you guys having me on. So I'm Trey Bateman. I am a neurologist with subspecialty training in behavioral neurology and neuropsychiatry. I practice at Wake Forest University School of Medicine, as well as at the Salisbury VA Medical Center. I'm from North Carolina. I was born and raised in Eden, North Carolina, and attended undergraduate school at UNC Greensboro, and then medical school and residency at UNC Chapel Hill. So I've been in North Carolina for essentially my entire life, with the exception of 1 year for my fellowship, and I'm really happy and proud to be back in North Carolina. Serving the people here, mostly focused clinically on dementia and related Alzheimer's disease and related dementias. And in particular, I'm really interested in the role of chronic psychosocial stress as a risk factor for developing these types of illnesses. And I'm also interested in the role of these, what we sometimes refer to as neuropsychiatric symptoms, things like mood disturbances, anxiety, irritability, and the like, in early neurodegenerative illnesses.
Awesome. Well, thank you. We are, like I said, in for a treat having this conversation with you. And offline, you and I can talk a little bit more because I too am interested. I did my doctoral work, PhD from VCU School of Medicine, and I studied the impact of psychosocial stress on disease management. So you and I will talk.
A lot in common.
Yes, a lot in common. I am with you. You know, my hypothesis is that a lot of some of the degenerative and chronic disease and illnesses, there's a correlation between stress. And so when we talk about mental health, people think about it in terms of, you know, the DSM-5 diagnoses. So your bipolar, your depression and anxiety and the like. Tell us, what exactly is the link between a healthy brain and some of the onset or manifestations of some of those mental illnesses or mental health?
Yeah. So one point that I always like to make when explaining to people what I do and sort of my clinical background, behavioral neurology and neuropsychiatry as a subspecialty really begins with the idea that mental events are brain events. And so when we are talking about these mental illnesses, you know, there is no mental health outside of brain health in many ways. They are manifestations of either brain dysfunction that can be generated by environmental exposures or from, you know, genetic differences or baseline neurological differences. But fundamentally, we know that there are brain events and brain differences in folks who have these symptoms that we classify as mental illness. In my work, one of the things that we focus on is things like depression. There's a long history of looking at depression and its relationship to dementia, and it's been really hard to tease apart the ways in which it's related. There's sort of three general hypotheses about this, and like most things in science, the reality is they're probably all true to an extent. And so, is dementia in midlife a risk factor for developing dementia in later life? And it turns out that it does seem to be in some studies that if you have midlife depression, that increases your risk of developing dementia in later life.
Mm.
Now, why does that
Why
happen?
is that? Yeah.
Yeah,
Why is
so
that?
great question, right? There's probably shared genetic and environmental risk factors for both midlife depression and later life dementia. And so, if you are exposed to stress, if you are exposed to environmentally adverse conditions, that makes the likelihood that you develop many of these mental illnesses higher in that sort of, diathesis stress model, so that we all have some baseline risk. And then when there's environmental or psychosocial stressors added to that, that may be the thing that triggers those mental illnesses in people that are more vulnerable. And that same biological risk may be shared with later life neurodegenerative illnesses. So that's one possibility. The other possibility is that depression itself is simply bad for your brain. That there's inflammatory changes and differences with people experience with some individuals who are experiencing major depressive disorder, and that those chronic inflammatory changes may in fact increase our risk for later life dementia, later life neurodegenerative illnesses. And then finally, there's this other question of, are these so-called mental illness, these mental health conditions, are they actually prodromal? So do they occur from those diseases as an early manifestation of dementia? And it turns out that's probably true as well. So when we break depression down, we look at midlife and late life depression. And we know that if we look at folks who develop dementia or cognitive impairment, and you look several years before that, depression and other behavioral impairments go up. And so those we think are occurring in the setting of prodromal illness. So people that we know.
Like what? Describe what those are. Explain what they. So like.
Yes. So one of the areas that I'm really interested in is called mild behavioral impairment. So some of our listeners it's helpful to kind of know the cognitive spectrum that we talk about to put this in context. So when we think about Alzheimer's disease, dementia, that's not where the illness begins. So we know that you can look at these pathologies in people that are clinically normal. So folks that have no cognitive impairments, but when we look at biomarkers, they in fact have those markers of neuropathologic change. That leads into eventually milder cognitive changes, but not dementia, meaning that we can measure those cognitive differences on our tests, but people are doing okay in day-to-day life. They're not having that functional impairment that's a hallmark of dementia. And then finally, if for these degenerative illnesses, that progresses and gets worse, and then people have functional impairment. And so there's a years or decades long process in developing these neurodegenerative illnesses that 20 years ago, we were only starting to recognize before the dementia stage. And as time has gone on, we've moved the clock back further in that pathological cascade to try and identify the very earliest changes in pathology and the very earliest symptoms. And so as we've done that, we've for a long time, we've recognized there's behavioral differences in dementia. People who have Alzheimer's disease dementia and other dementias very commonly have agitation, hallucinations, depression, irritability, anxiety, all of these things. But
So just for the public who, the lay person, the person who hasn't studied this extensively or studied it at all. So, So do you think that that's simply continuing behaviors that they had prior to,
No.
or okay.
Yeah. One of the things that I spend a lot of time in clinic talking with my patients and families about is the notion that behaviors are fundamentally brain events. And so there is no such thing as a psychiatric symptom that cannot be manifest from a so-called organic or structural problem in the brain.
Mhm.
And so I've seen folks who have all manner of behavioral or so-called psychiatric symptoms that are causally attributable to their brain disease.
Mm,
And so we see a lot of individuals who have no history of psychiatric disease, but with the onset very early with these pathologic changes, before they have dementia, they may start to develop persistent, lasting behavioral changes. So a good example of this is, um, somebody who's in their 60s who may develop depression kind of out of nowhere, not necessarily a huge grief or stress response, but they've developed persistent depression that's present for months on end. Um, that is a risk state for going on to develop cognitive changes. Certainly not everybody. And I don't want anybody listening to this to think that, everyone who develops depression in their 60s is going to go on to develop a cognitive disorder. They're not. But they are at a higher risk. Just like if you have high blood pressure, you're at a higher risk of having a heart attack. It doesn't mean that you're going to.
right.
And so these are changes that are truly driven by the developing pathology in the brain from brain changes. And
Right.
so it's very different from folks who've had a lifelong.
Oh, right. Got it. So what can we do to protect our brain from like,
So that is a great question. It's one that I find that I get in clinic almost every time I'm there, because even if I'm talking to somebody who, they have severe dementia, their families want to know, like, what
Mhm.
can I do to reduce our risk of this?
Yes.
So a couple of things that I tell everybody. There's no supplements that they need to rush out and take. Most of them have no data to support them.
So
Um,
not even omega-3?
well, okay. So omega-3
Right now?
maybe helps with some vascular disease,
Mm,
and that may be helpful. But I'm thinking more of, these. If you go into any health
yeah.
food store,
Right.
you'll
We
see,
won't get in trouble by
sure,
calling anyone out, but yeah.
exactly. Yeah, I don't want. Yeah,
Right.
no, I don't.
But
I don't
there's
want.
no but the main point is there's no supplement or anything people can take to protect their brain?
No, no.
Oh.
There's really not. There's no good data to
Well,
support
I'll
that.
get rid of about 3 of them that's on my counter, in my
I mean, now, look, if you're vitamin deficient, it's not true. You do need to take, you need
Right.
to not be vitamin deficient.
Yeah.
If you're, taking omega-3 to help with cholesterol, low cholesterol is good. But, I get a lot of folks that come in and say, well, this was on the counter and said it supports memory function.
Mhm.
And there's just none of them that do. And the reason that I start out by telling people that is because there's a lot of folks that experience financial toxicity from that. They may be spending, hundreds of dollars a month on those things. And so we start there, but I also talk to them about what we do know. And the data that we have is that there are some things that people can do that seem to lower the risk of future cognitive disorders.
Okay, what are those?
All right. So the top two are diet and exercise. Diet and exercise are really, really important. There's good evidence that getting consistent cardiovascular exercise around 150 minutes a week or so seems to be beneficial for your heart and
Does
your
it
brain.
matter what I do? If I'm a runner versus a walker versus a,
Just getting your heart
biker
rate
versus
up.
just
Just
get the
getting
heart
the
rate up.
heart rate up.
Okay,
Yep.
listening, those of you who are listening, just that's key. You don't have to go out here and start training for a marathon. Just get the heart rate up and at about 150 minutes a week. So, you know,
And
30,
look, some is
right,
better than none. So if you can't
right,
get to 150, that doesn't mean you failed if you've only done 30
right,
this week.
right.
It's all a process. We're all trying to do better.
Yeah.
So that's one thing. The other thing is diet. And the diet that seems to have the best evidence is called the MIND diet, MIND. And that's basically a Mediterranean style diet with some low salt added in. So it's kind of a combination of two other popular diets called the Mediterranean diet and the
Yeah.
DASH diet for salt. And so you can Google that and find all manner of recipes um, to give you things that you can eat along that. Those both have pretty good evidence for helping to prevent cognitive decline.
And Dr. Bateman, what is this about sugar? Should they avoid sugar at all costs? Is sugar really bad for the brain?
Um, so too much sugar is bad. We want to avoid things that are really, have really bad glycemic indices and the like. And there's ongoing studies looking at the ketogenic diet, which is a really low carb diet. It's a study that we've been doing here at the Wake Forest Alzheimer's Disease Research Center. And so there are some people who think that, a really low carb diet may be better. The data are still developing for that. So in general, my clinical advice is still to kind of look at the MIND diet, follow that as best as you can.
Okay. All right. So exercise and diet. What else?
Those are two. And I will also point out, since this is, this is a mental health link here, those things are also good for mental health, right? We know that exercise helps with depressed mood and major depressive disorder, especially on the milder end of the spectrum. So, and there's been work on the same diet, the MIND diet, in depression and other mental illnesses as well. So these things, again, are linked. And so those two things also have a link to mental health. The other thing that we talk about is staying cognitively active. We know that folks that stay cognitively active seem to have a lower risk of developing cognitive impairment. And people always ask me, well, what do you do? Like, what do you
Yeah,
mean
what does that mean? Like, is it Sudoku or is it puzzles? Is it what is it?
So my advice, so that the data aren't great for any one thing. And so my advice to people is what you like to do. And there is no evidence that one cognitive activity is eminently superior to another. And so if you like word search, great, do word search. I personally, and I'm going to say something that's unencumbered by as much data, but I gave a talk at the neurology conference this year about video games and cognitive stimulation. And so I personally think that folks that are engaged and active in playing video games, that's cognitive stimulation. There's nothing.
There has to be a limit, though, because there are some kids and some people, adults too, that are playing a lot of video games that I wouldn't think it's healthy.
Everything in moderation.
Screen time. Yeah.
Everything in moderation. But I have some older adults that, they are playing solitaire on an iPad. I think that's fine.
Yeah.
I don't think there's anything inherently better about word search or Sudoku compared to other forms of mental stimulation. If you like to read, if you like to play bridge or play card games, any of those things are good. If you have to force yourself to do it, you're not going to keep doing it. So I would rather people find something that they are really invested and engaged in for that cognitive stimulation. And then one that comes up a lot is loneliness. So this is getting a lot of press lately.
Yeah, it is.
Murthy as the Surgeon General is talking about loneliness as being an epidemic. And we know that loneliness, and just to be clear, loneliness for our listeners, loneliness is not being alone; it's feeling alone. Loneliness, by definition, is a subjective sense.
That's an important point.
You can be lonely around other people, and you can not feel lonely when you're isolated.
Right.
So it's really that.
Yeah, I say that, especially when people say, when you hear about a major social media influencer taking their life by suicide or something, and people say they just felt that they were isolated, that they were lonely, and so forth. And then others may chime in and say, well, how could they be alone? They had 1 million viewers, they had a million followers or whatever. Yeah, so
Exactly.
that's an important distinction. It's that subjective, it's how you feel. Yeah, you
Exactly.
can be you can be in a room full of people and still feel lonely, right?
Loneliness is another risk factor for many mental illnesses. One of some of the research that we're doing here at the Wake Forest Alzheimer's Disease Center focuses on a feeling of loneliness in our participants during COVID, and been looking for effects of loneliness during COVID and how that is impacting their cognition and their well-being. And so we've got diet, exercise, staying socially active or avoiding loneliness, uh,
Cognitive
cognitive
challenges.
cognitive engagement and activity. Sleep is really important. Uh,
Uh-oh.
yeah, right. Yeah, that's a hard one for. I have two young kids, so believe me, I know it is hard to get enough sleep. Um, there's different kinds of sleep problems, right? And so one thing that I think many of us strongly think is that sleep apnea is often woefully underdiagnosed and a real problem uh, for cognition. And we think that treating sleep apnea may lower the risk of many of these degenerative illnesses, um, in part because sleep is not the same thing as being unconscious. And that's really important. So you can be asleep, you can feel like you're asleep, but if you have moderate or severe sleep apnea, you're waking up 15 to 50 times an hour on when we measure your brain waves because you're having those episodes of not breathing and not getting good oxygen. And so it is disrupting that active process of going through your sleep cycles. So I see folks that come to me for an evaluation for dementia or for a cognitive impairment. And I have a handful of folks that really the problem is they have sleep apnea, and you treat their sleep apnea and their cognition gets better because turns out not sleeping for nights and nights and weeks and months on end is really bad for your cognitive functioning.
Right. And why is it? I'm guessing because it just doesn't allow your brain time to regenerate, to refresh and
Yeah, so sleep is kind of like the garbage disposal system of your brain. So when we're awake and our brain's active all day, we are producing all sorts of byproducts of metabolism and just being awake. And when we're asleep, our brain that's part of what our brain's doing there is it's clearing those things out through some other physiologic mechanisms. And if you are disrupting that sleep, because what happens with say sleep apnea, obstructive sleep apnea, is that you stop breathing or your oxygen drops really low. And if we measure your brain waves while that's happening, normally people will cycle through the stages of sleep. They go from light sleep to deep sleep to rapid eye movement sleep and then back up and down and up and down. But every time that you have one of those episodes and stop breathing, you'll see people go up into that light sleep, or essentially their arousal is increased, and so it's disrupting that normal process. So your brain is not getting restful and restorative sleep.
wow.
It can be hard to convince people of that because you've got to wear this mask. It's very uncomfortable for some folks, and they kind of have this feeling of, well, I'm asleep, it doesn't bother me because I'm unconscious during that period of time, but it's really disrupting the quality of the sleep. That also, just to tie it yet again to mental health, it is not uncommon to see folks who come in with kind of a atypical depressive syndrome, agitated depression, and sleep apnea can be a cause of that. And so,
Well, I want to bring you back to talk about sleep and how you can get better sleep and one, get a diagnosis. I'm assuming you would have to go to a clinician to get a sleep study, participate in a sleep study. But I'm also hoping that there are other ways to deal with sleep apnea other than wearing that machine, whatever that thing, I forget what it's called now. So like
an auto PAP or a CPAP.
CPAP. That's right. Those things, oh my goodness. But so I do wanna we'll have to have you come back to talk about sleep if you are willing. That would
Sure.
be great. I'd like to talk about that. And I also like to talk about how the brain, operates. I don't think a lot of people are aware of this amazing organ in our body, right? Um, and what it needs, and how even ACEs, adverse childhood experiences, can be harmful. We only have a little bit of time left. What's the emerging or the research around brain health? What is it focusing on these days?
Yeah, so a lot of what we're seeing now is moving from identifying associations into trying to demonstrate that intervening truly helps. And so let me explain that. It's really easy to show that when you take people in midlife who are active, they have a lower risk of dementia. That's a separate question from, can we take people who are not active,
Mm,
make them active, and lower their risk of dementia?
mm,
They're
mm,
you might, it's easy to sort of assume that those things may be true, but medicine and science is replete with instances of finding an association and then not truly lowering the risk by doing something about that association. So we have a number of trials that are focused on these interventions, and I'll tell you about one of the biggest ones that's actually going on in part here in North Carolina. Several years ago, a study called the Finger Study came out, and this was in Finland, and it was a multimodal brain health intervention to reduce the risk of dementia. And they, instead of just doing one thing, they took all the brain health things and they developed a program to do. They had cognitive engagement, they had diet, they had exercise, and they had people engage in all of these. And the folks that did had a lower risk of dementia 5 years later. And so that study has now expanded and ballooned to many examples across the world. One of the biggest here in the U.S. is called U.S. Pointer, and the one of the main principal investigators is here at Wake, Dr. Laura Baker, and she has really made a career out of being a trialist and an interventionalist in these non-drug interventions. So it's trying to show that dietary changes and exercise-based interventions can in fact lower the risk of cognitive decline and dementia.
that's awesome. We'll have to have your colleague on. That's so we do know there are certain groups that are at highest risk for or higher risk for um cognitive decline. Specifically, I'm thinking of Black women and Alzheimer's. What's
So
going on?
So that's a great question, and it's a huge example of inequality in diagnosis of things like Alzheimer's disease. So we know that Black Americans have about a 2 times increased risk. Uh, uh, Hispanic or Latinx Americans have about a 1.5 times increased risk, and we know that many of the differences here are not going to be there's not a
Genetic,
biological
right?
reason. It's not a genetic
Mhm.
difference. And so we suspect that one thing that is frankly different is exposure to racism and stress. And we know that exposure to racism, stress, social adversity, the unequal exposures that happen as a direct result of that change risk throughout the life course.
Mm.
And so this is a major area of interest and work here at the Maya Angelou Center for Health Equity Research, MAISH, with Dr. Goldie
Oh,
Bird,
the bird, yeah.
and she is phenomenal. She should be a hero to all of us. Has done amazing work in this space, but there's and is really done work trying to focus on helping to change that risk and intervene specifically on those groups that have higher bear that unequal
Mhm.
burden of risk. And so we think that's probably a lot of it, is these differences in unequal exposure.
Dr. Bateman, this has been a wonderful conversation, and I want to have you back on because I think we've just scratched the surface of topics that we can, layers to this topic that we can look at. That's so important. I hope our listeners have gotten or gained a lot from this. And um, I never like to end without asking our guests two things. And if you've been a listener of our podcast, so the very first one is what books are you reading or have read that you would recommend to others? And just up to three. It doesn't have to be a whole.
Does it need to be related to what we're talking about?
No, it doesn't.
Okay, great. Okay, well then, so I am a sci-fi fantasy nerd. That's what I read in my spare time. I read sci-fi and fantasy. So I will recommend an author and more than three books because it's everything by this author.
Okay.
Brandon Sanderson is, in my opinion, one of the best modern fantasy authors. And the easiest series to start with is called the Mistborn trilogy.
Okay.
And so, anything by him is just fantastic.
Brandon Sanders. Okay, great. And finally, what do you do to take care of yourself, your mental health? What do you do?
So one of the themes to my work that we didn't talk about that bears on this question is the role of meaning. And we know that things like purpose and meaning in life are really, really important. Both biologically, psychologically, across the board, purpose and meaning are important. So one of the things that gives me tremendous purpose and meaning in life is my role as a father and my family. And so, when I'm feeling stressed, when I'm feeling overworked or overburdened, there's very few things that help sort of recenter me more than spending time with my family and my children. At the same time, they stress me out sometimes, like they do all parents, but they really deliver that purpose and meaning very, very much.
Awesome. It has been a pleasure. Thank you for being a guest on Public Rounds, and thank you all to our listeners and those of you who continue to follow and continue to listen. If there's a topic that you'd like for us to cover, please reach out to us at the Medical Society and follow us on our social media accounts. We're on all the platforms. And also, if you want to find out more about the Medical Society, the work that we do, we are the professional organization for North Carolina physicians and physician assistants. Now, there are specialties, but we are the organization that represents across all specialties. We are the house of medicine, as some say. So thank you all for tuning in. Go to our website, www.ncmedsoc.org. You can always send your request for a topic to me, and that's MLAWS@ncmedsoc.org. Until next time, take care of yourself. Take care.